Good afternoon, and welcome to today's webinar, Defining Population Health Strategies. I'm Georgia Maharis, the Vermont Healthcare Innovation Project Director, as well as Deputy Director of Healthcare Reform for Payment and Delivery System Reform at the Agency of Administration, and I'll be moderating this afternoon's webinar. This is the second event of the VHCIP's new webinar series, which will be occurring monthly on second Wednesdays for all of 2016. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On the left side of this slide, slide 2, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane, and the dial-in information will be displayed. We have set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. During the Q&A session, we'll have a moderated discussion to answer your questions. Today's event is being recorded. The slides and recording will be posted to the VHCIP website within the next few days. You will be notified when these materials are available. At the end of today's event, you will be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank Chrissy Geiler and Sarah Kinsler for planning this webinar and taking care of our logistics for today. Our presenter today is Heidi Klein. Heidi Klein serves as the Director of Health Surveillance at the Vermont Department of Health. Heidi possesses over 20 years of experience in public health practice, public engagement, and collaborative planning. She worked with leaders at the national, state, and local level to design programs and policies which recognize the interconnection between public health, environmental protection, and economically vibrant communities. She is past president of the Vermont Public Health Association and has served in multiple capacities for the American Public Health Association. In addition to her day job at VDH, she provides invaluable support to the Vermont Healthcare Innovation Project as staff for our population health work group. Welcome, Heidi, and thank you for joining us today.
Okay. Thank you very much for having me. It is my pleasure to be here today. I'm just trying to advance my screen. So for today's agenda, my hope is to share with you some of the background that we have been doing under the Vermont Healthcare Innovation Project in defining population health strategies. Pausing because I am having a hard time getting my slides to advance.
This is Georgia again. Thank you so much for your patience. We're actually going to change computers and who will be running the slides so that it's a little easier to advance them. So if you'll bear with us through this technical glitch, we will get started again in just one moment. And Heidi will be transferring the slides to Chrissy Geiler's computer from yours in just a moment. Thank you.
Okay. So Chrissy, if you're on the agenda, I can talk while you get there. Today what we're going to do is, thank you, Chrissy. She's moving us forward to the agenda page, which is slide number 5.
All right, Heidi, why don't you keep talking and we'll have the technology catch up to you. Thank you.
You got it. Okay. So first of all, I just want to set some definitions to help make it clear, because I find oftentimes in our conversations we're using the same terms to mean different things, and this can lead to a lot of confusion. So I'll start by sharing our definition of health. And by health, we have adopted the World Health Organization's definition, which is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think that in Vermont we have really embraced this idea of health and well-being. When we talk about population health, it really depends on where you sit. So when people talk about what is population health, for healthcare providers, that often means their patients. I'm on slide number 7. They're referring to the patients in their practice. When health insurers are thinking about population health, they are often thinking about the clinical outcomes of enrolled patients in attributed lives. There we go. That's that second circle. In the community, when people talk about population health, what they really mean is all the people who live in a geographic area. So really one's definition seems to be framed by where they sit and where they work. For this project, and as we've been talking about it, we have embraced the idea that it's not an either or, it's a yes and. So population health is each of those definitions depending upon where you sit and where your responsibilities lie for the improvement of health in our population. I'm going on to the next one. So population health is defined. I think there are some common shared understandings that we're really talking about the health outcomes, which means the morbidity, mortality, or quality of life of a group of individuals, including the distribution of the outcomes within a group. So this is really an important piece to consider. We are using the definition that came from the Institute of Medicine's Roundtable on Population Health Improvement. Again, what's different is we're saying it's the health outcomes of a group of individuals. We all share that. When the Institute of Medicine talks about it, and we talk about it here in Vermont, we are also very concerned about the distribution of those health outcomes within the group, recognizing that health is not shared equally by all, and there may be subpopulations who are experiencing greater health impacts than others. The other key thing that comes with our definition is an understanding that health outcomes are the products of multiple determinants of health. So we are looking at those things that contribute to health outcomes, and those include medical care, public health, genetics, behaviors, social factors, and environmental factors. So if you look in the top right of the screen, you'll see there's a pie chart. Oftentimes when people talk about improving health, they assume that what we need to do is fix the healthcare delivery system. And in fact, the Vermont Healthcare Innovation Project is within that. And what we have realized, though, if we really look at the determinants of health, what happens in clinical care, meaning in the healthcare system, in that healthcare setting, only accounts for 10% of health outcomes. So if we really want to reach the triple aim, which is improving health outcomes while reducing costs and ensuring high-quality care, we actually need to look beyond, because in order to improve health outcomes, we need to address these determinants of health. So if we go to the next slide, you'll see, so within the Healthcare Innovation Project, we have decided that we need to explain a little bit more about what we mean about population health. We mean taking a look at those multiple determinants of health. So we're focusing on, I'm going to go back again, focusing on the population as a whole and health outcomes and the distribution of those outcomes within a group, so that we're able to identify priorities for action and target appropriately to the subpopulations that might be at greatest risk or experiencing the highest negative health outcomes. We are looking at population at all three levels, at the clinical level, the community, and the practice level, and then at the community level. We're also focusing on prevention and wellness by the patient, by the physician, and the system. So again, we're looking at not only what do we need to do for this individual, but we need to be looking at what we can be doing at the different levels, and that we are looking at wellness rather than just treating disease. And by doing that, we are able, again, looking at the broader population, to recognize that while we may be able to improve the health outcomes of individuals who are already in our healthcare delivery system, overall our healthcare costs and our population health outcomes will not improve unless we take a prevention and entire population approach. Next slide, please. So how do we do that? Well, this kind of population health framework tells us to focus upstream and looking at risk and protective factors. And this is something that we hear across the board from folks who are working in a clinical setting to those who are working at community-wide prevention. We recognize there are things that people do, their behaviors and their personal health behaviors that impact their health. And so looking at those risk factors, those that lower the likelihood of a positive health outcome, and protective factors, looking at opportunities to protect from negative consequences are really important. And so we are looking towards not only diagnosing what's happening now, but looking at those contributing factors, those risk factors that are about individual behavior and personal choice. The next is to look at the social determinants and environmental factors. So while individuals may indeed be adopting either healthy or unhealthy behaviors, a lot of that is tied to the circumstances in which they find themselves. And what we know from the literature and what we know in practice is that the circumstances in which people are born, grow up, live, work, and age all affect one's ability to adopt healthy lifestyles or to avoid negative impacts. And so while we must indeed attend to a person's current state of being, the behaviors that they're choosing, we also need to look more broadly to those social determinants and environmental factors. Next slide, please. So what does that look like then? Well, I shared this kind of confusing graphic because it really shows us, for using an example of cardiovascular disease, what it means to take a multiple determinant approach rather in conjunction with a clinical approach. So you'll see on the left-hand side of the slide that there are certain actions in that blue that one would do in using a clinical approach to address cardiovascular disease. And as you'll see, it's mainly about access to care and the quality of care. And that enables us to address what's happening to the individual in the moment. However, if we take a multiple determinant approach, we are able to look at a whole wider range of factors that are influencing an individual's health outcomes and recognize that that means the scope of service we provide and the factors that we're trying to influence therefore must be broader as well. So you'll see that means we need to start looking at behavior, clinical care, education, nutrition, income, social support, and the environment. By recognizing that there are all those domains, it means that when we come to looking at measures, we have to look at different ways of measuring our outcomes and our impacts, because we want to not only hold accountable what happens in that clinical setting, but also hold accountable other partners and other factors. And that's what those stakeholders, that's why there are so many stakeholders listed there that are beyond our medical care partners. So in recognizing a multiple determinant, the multiple determinants of health and the social and ecological factors that influence our health, it also recognizes that many more players need to be engaged when we are talking about improving population health outcomes. And so we need to recognize that we're looking at not only healthcare system reform, but some other reforms that will need to take place. Okay, next slide, please. So I share with you, this is the Vermont prevention model that we use here at the health department. That is a way of helping us to conceptualize the different layers of change that are needed in order to actually impact an individual's health and improve population health outcomes. So you'll see what this does for us is it's based on a social ecological model. It recognizes that there are multiple levels of influence on health. In the bottom there, in the smallest circle, is the individuals. And this is where we are really working on what do people know, what do they do, what do they believe, and what is their current health status, and how are they engaging in the decisions that are needed to improve their life. So for diabetes, for example, that would be ensuring that people have access to care and that they are doing what they need to do to improve their health, such as self-monitoring for blood glucose. It also recognizes that the choices that we make and our individual behavior is shaped by our relationships, our families, our peers, our social networks, and our associations. So if we really want to support an individual, we actually need to provide some peer support. And that's why we really promote the use of peer support diabetes self-management. Now, that's also contextualized in the organizational setting. What are the ways in which our organizations, our schools, our workforces make it possible for people to cultivate the relationships and make those independent changes? So what you'll see is there's a role not only for the individual, but here there's a role for others, such as what our nurses are doing in the schools, whether or not there are worksite wellness initiatives that might help to affect diabetes through maybe self-monitoring of blood glucose, but also recognizing that diabetes is affected by what we eat and how much we move our bodies, and there's lots of ways in which worksite wellness can affect that. At the community level, we can also make changes that make, like what we like to say, the healthy choice the easy choice. And how do we do that? We make choices easier when we have structures in place and we have institutions and infrastructure in place that make it the default that one would be healthy. So our Healthy Retailers project focuses on the promotion of fruits and vegetables. And so you may have seen in Vermont, we are doing a lot of work to try and make sure that even our corner stores or the gas station stores are putting healthier choices at the cash register. That's a way of engineering, making the healthy choice the easy choice. And that's something that is in sort of what's happening out there in the community that really can fundamentally shift the choices that people are making. At the policy and systems level, which is the sort of the overarching, we need to look at the way that local, state, and federal policies and laws, as well as economics and media, affect the choices that people make. And here, choices about access. And so through the Healthcare Innovation Project, we have talked a lot about access to services for health. And that's where the reforms that we are making in our healthcare system can be so critical in terms of what are we offering to everyone so they have access to care, they have access to healthy foods, they have access to programs that include peer support. So I hope that this gives you a sense of how we see population health is the strategies are at multiple levels of intervention, and this is to show you that there's not a belief that there's one right level of intervention, but rather we need to be working simultaneously at all levels. So I'd like to go on to the next slide and just show you how that works. So for our partners who are working really in the clinical world, what we've adopted is trying to frame it in a way that we can collectively get our brains around so that we can see how our complementary efforts build towards population health improvement and positive health outcomes. So there's sort of three buckets of approaches that are being promoted through the Centers for Disease Control and Prevention and CMMI, the Center for Innovation at CMS. So the first is some traditional clinical approaches. Those are the things that we can do in a clinical setting that would affect health. And so they focus on individual health improvement for patients who are using provided-based services. The next bucket, if you will, is innovative patient-centered care or community linkages. And that's where individual patients are connected up with community services. I would say that so many of the innovations that we have seen over time here in Vermont, where our blueprint has really led the way in focusing on first making sure that everyone has a primary care medical home, and then expanding what happens in that medical home from beyond traditional clinical approaches to this innovative patient-centered care with community linkages is really what a lot of what is happening now in Vermont in terms of moving from a primary care medical home to really looking at that integrated services for individuals who have needs. And so there's been some tremendous work here in Vermont with the blueprint practices, partnering with our ACO leadership to look at ways in which they can identify some shared goals and metrics, and really focusing on that range of services that will help address some of those multiple determinants of health for the individuals who are being seen in the practice or who are part of the attributive lives in our ACOs. And so there's really a concentrated effort for those who are already in some kind of medical care to connect that with behavioral services, mental health services, and now housing and economic services in a way that hasn't been there before. And so I think in Vermont we're really seeing that we have embraced this notion of looking at multiple determinants of health, thinking beyond the individual's medical situation to engage more broadly. In the third, what we see are the community-wide strategies for improving population health of the population overall. We have historically had quite a bit going on through our public health sector and some of our advocacy groups that have really been working well on population-wide community strategies to affect population health outcomes. Historically, there's been a bit of a disconnect between what's happening in our clinical care settings and the work that we're doing in our medical care and that which is happening on the population health community-wide services. And what we're hoping to do is recognize that there's an interconnect between the three. So I'm going to give you an example of how we continue building on this model. So for somebody with diabetes, I'll go back to that example. In the traditional clinical approach, what would happen is an individual would go to a doctor and they would find out that they had diabetes or perhaps were pre-diabetic, and they would be tested to make sure that the diagnosis was correct, and then they would be given medication to try and manage their diabetes. Over time, we've recognized that that is a good starting point, but it's insufficient. That individual probably needs to also be looking at their lifestyle issues, their behavioral choices, and they may need some coaching and assistance in adopting healthier practices. So now we've moved from a diagnosis with a prescription or treatment to thinking about what kind of other healthy behavior supports might an individual need. And we have expanded from to creating and offering support groups to individuals with diabetes, to peer networks, to providing them with nutrition coaching or with physical activity coaching. So we've brought in a bigger range of supports for that individual. If you start asking about some of the other social determinants, you might find out that that individual not only is missing, might not be able to adhere to their medication or to good physical activity or to strong nutrition practices because, in fact, they don't have stable housing. So they have no place to refrigerate their medication. They are having a difficult time having healthy foods because they, again, no place for their foods. And physical nutrition and physical activity and nutrition may not, in fact, be one of their highest priorities when they're looking for housing. So we've now moved into that innovative patient-centered care with community linkages because we are now saying, we really need to partner with a housing agency or economic services to help this individual get stable housing. And in fact, we have some really interesting innovations here in Vermont where folks are asking that question and some pilot projects to see if providing housing indeed would have a positive health outcome for diabetes. And in fact, it does. That's still looking at an individual case and making sure that individual has the services they need. From a community-wide prevention strategy, what we would be saying is, do we have enough stable housing to meet the needs of our communities overall? Who needs to be engaged in thinking about that? And so that might lead us to a whole different set of partners. It would lead us to partnering with people who are in local planning, who are part of economic development, who are part of housing and urban development. And all of a sudden that opens up not only our partners, but our strategies and our resources, both for the individuals who are currently at risk and are experiencing difficulties medically, but who are also, we are setting up a system to prevent that next wave of folks who are pre-diabetic or who are at risk from developing diabetes in the first place. So ideally, our population health strategies would include all three levels. We need to treat people who are already experiencing negative health outcomes, who are already diabetic. We need to recognize in order for them to maintain health and improve health, they need to be connected with the community linkages. And in order for us to think about our community overall and to ideally address the triple aim, which is reducing costs, improving quality, and ultimately improving health outcomes as a state, we need to incorporate these community-wide strategies. So I want to share with you one last slide, and that is the next one, please. So here's an example if we use developmental screening in the first 3 years of life. And this is, I shared this with you for 2 reasons. One is to, again, show you how we've begun to think about those 3 areas of intervention, or the 3 levels of strategy for improving population health. And, this is an example of what we will be doing for each of the ACO measures that are currently in play in the state of Vermont. So you will see here, this is the ACO measure, core number 8, developmental screening in the first 3 years of life. And what we've done is we have consulted with folks who are engaged in medical care and in community-wide health strategies and said, what are the evidence-based best practices or the emerging ideas that we think would help us to really improve population health in each of these settings? And so you'll see there are clinical approaches such as screening and looking at using a tool in the 9, 18, and 30-month well visits for pediatricians. There's also in that column, there's training and to ensure that our practitioners and staff know how to use a screening tool, and that's a lot of the workforce development that we've talked about in our healthcare innovation. In the next column, which is about innovative patient-centered care and community linkages, you'll see we're moving from treating an individual to offering education to them to look at ways in which they can change their behaviors or influence their own health outcomes. And then it's also building partners with folks outside of the pediatrician's office. So there are referrals that could be done related to early childhood screening. And then last, there are community-wide strategies. Are there ways in which we can look at improving the environment, whether it's the social, economic, or educational environment in which our families sit, so that they are better able to support early childhood? So that's one example. As I said, we will be putting together what we're calling these change sheets that show how one moves to population health improvement. Again, going back to, sort of our thought about, well, what is population health and what are population health strategies? It's really recognizing that we need to be looking at all the multiple levels of intervention, what we can do in our clinical practices, what we can do when we are working in terms of expanding the range of services for individuals in those patients in practices, to connecting with community-wide strategies that are about population health improvement and prevention overall. So that's a very speedy review of what we mean by population health in the Vermont Healthcare Innovation Project. I probably jumped over a bunch of concepts, and I'm more than happy to answer questions. So I'm going to turn it over back to our moderator to work on the question and answer time.
Thank you so much, Heidi. Appreciate your presentation. As Heidi indicated, we will now take questions from participants. As a reminder, you can submit questions by typing into the questions pane of your webinar control panel. I'll facilitate our Q&A session. Our first question is, how can healthcare providers impact social determinants identified in the social economic model? Heidi?
Sure, that is a great question, and I have to say, when I first started chatting with clinicians about this, initially there was a, what are you talking about? I don't understand what you're talking about. Then we moved to a sense of, I know these are important, but what am I supposed to do? And there was, frankly, a bit of a sense of being overwhelmed, because as we know, people who are working in a clinical setting are already very pressed for time. So what can they do in a clinical setting that recognizes the social and economic determinants of health and the others. And I think part of that is developing some of the screening tools that are, developing and using some of the screening tools that are available, and it's about what questions we're asking. And so first is to know what are the behavioral factors that might be influencing these health outcomes, and being very attentive to behavioral factors. The second is to understand the life circumstance in which one is working, and to build into your practice, to the extent possible, some of these other referrals and linkages to other providers who both have the time and the knowledge and expertise to help address some of those social determinants. So from a behavioral perspective, as we've seen in our blueprint practices and in some of our other innovative practices, we've moved to having behavioral specialists. And what I mean by that are folks who are trained in nutrition, who are trained in mental health, who know how to use motivational interviewing to help patients or clients understand their opportunities for changing their behaviors to improve their own health. And so that's really one part that one could do in a clinical setting. The other is to consider the resources and connections out into the community. And I know an individual practitioner may not have time to do that, but having, working with other clinicians, working through us, we can, in the Healthcare Innovation Project, there are many tools that are available to at least have a handy list of referrals, some excellent screening tools, and hopefully with some of the innovations that are being tested now through the Care Models work group of the Healthcare Innovation Project, there will be a greater ability to use the evidence base in a clinical setting to address some of these social determinants. I hope that was a helpful answer.
Thank you, Heidi. Another question we have is, how are population health and public health funded now? Is thinking about how to get to the next phase of how do we continue the great work that we've started, and so building off of our existing funding streams into the future.
Right, right. Thanks for the question. So as some of you may know, we have been working on proposing a model that would be functioning at the regional level called Accountable Communities for Health, which have 9 dimensions. And it's a model where we're trying to do some testing and exploring about how we connect what happens in clinical settings and in healthcare settings with some of our population health and community-wide prevention efforts. And probably one of the most difficult pieces that we have right now is thinking about a sustained funding that's sensible. So right now, our community-wide public health system is primarily funded through our state, a health department, and most of that funds comes from federal funds through grants rather than statewide investments. And so a lot of sort of that community-wide prevention work that we're able to support out in the community comes from various grant sources, which is phenomenal. We have been incredibly successful in getting support, which is great, but it is always tenuous in the sense that it comes with a grant, which means it has a defined set of deliverables, and it's over a defined set of time, which means it's not necessarily reflective of what communities are identifying as the primary health challenges and opportunities for change in their own communities. So ideally, we would be moving towards a more sustainable funding mechanism that can actually be driven by community needs and resources. We have been watching how in other states, through their healthcare innovation projects and other efforts, have been looking at the changes in their payment models on the healthcare side to look at investments in improving population health, whether that be in the clinical setting, that sort of innovative care setting, or community-wide prevention. And some of them are doing it, and they're testing out some per member per month payments that would go specifically towards community-wide prevention services and the integration of care. Others are looking at a percent of total health care costs, so the total cost of care, an outright percent of that would be dedicated and managed either at the regional level or at the state level, and that the investment would go again into the sectors that are looking at innovative care and integration of services for individuals, or looking further out to that community-wide prevention. And so they're looking at that through a percentage of the total cost of care. So that's one mechanism, is to really look at our current payment models within our health care delivery system. The other is to look at alternative financing opportunities and models, and we've begun exploring that. And so ideas that you may have heard of include looking at a prevention fund, such as what they've done in Massachusetts, where there's actually separate funding that was set up, and that has a few $1 million a year. I regret that I forget the exact source of funding, but maybe Georgia will be able to answer that when I'm done talking. But in Massachusetts, they now have a prevention fund, and communities are able to get grants through that specifically to do some of these more community-wide prevention efforts. In other places, they're looking at actually using economic development funds, since, as we know, some of the determinants of health have to do with economic development, whether it be housing or job creation. And is there a role there for using funds and partnering for improving health that way? So those are just a couple of little examples. We do have, we're lucky to have here in Vermont a group of folks who are looking at alternative financing and payment models, and more to come on that.
Thank you, Heidi. And the Massachusetts Public Health Trust was actually built off of specific funds dedicated from a handful of hospitals that had significant revenue increases a few years back. So the legislature did a one-time assessment to them to $50 million into a fund. So I did know the answer to that question. Thank you so much. I think just one final note, because we don't have any more questions that have come into us, and that is, if you would mind just one more time reminding folks about our learning lab, what the point is, what we're hoping to accomplish, and really some of those specific pieces of information that's such an exciting next step in our work.
Absolutely. So one of the things that, in our time through this Healthcare Innovation Project, we have sort of slowly built our knowledge and developed some recommendations on how to move forward if we really wanted to look at improving population health outcomes at the community level. And so we are building upon the work that we invested in asking the Prevention Institute to take a look nationally as well as here in Vermont for where we were noted, where they could find examples where other communities or our own communities have really started to look at connecting the dots between clinical care services for individuals and population-wide prevention strategies. And what we're calling it is Accountable Communities for Health, because what we have noticed is that in order to merge those and create a model that might work, we are really looking at moving from not only statewide accountability and individual accountability, but we also needed some accountability at the community level that addressed the population of the community. So we are building on the great work that has already begun here in Vermont with the emerging collaboratives between our blueprint practices and our ACOs, the Unified Community Collaboratives, the UCCs, recognizing that in those areas they have already begun to try and look at how do we develop some concrete measures and some care plans and innovative strategies that would help us improve population health. And what we hope to do is add on to that some additional partners who are really looking at community-wide prevention and the social and economic determinants of health. So we are about to launch what's called the Accountable Community for Health Peer Learning Laboratory. So in our first phase of Accountable Communities for Health, we, as I said, had worked with the Prevention Institute to help us outline sort of a model of what we think, based on some of the leaders in the nation, as well as the really clever work that's being done here in Vermont, what would we be looking for in a model for an accountable community for health? And we had 9 different factors for that, including a shared sense of purpose, shared metrics, a governance structure, accountability through for financing and for measurement, and for the population overall. And what we realize is it's a fabulous conceptual model because it was built upon what's already happening, but it's never been tested. And what we really need now is, before we go to those next steps of figuring out how to systematize a model, or how to make sure that we have the policies and structures in place in Vermont to be successful, we really need the feedback and learning more intensely with the folks who are really trying to innovate on the ground here in Vermont. So we're pulling together what's called a learning lab, and the idea is that we are going to learn with and from the participants who have already established some really strong relationships at the regional level, who are interested in seeing how we sort of broaden into this third sphere of community-wide prevention strategies. We will be bringing folks together for 4 to 6 in-person peer learning laboratory sessions, where really it will be a series of structured dialogues and investigations to find out what people are doing, where they're finding success, where they're finding struggles, specifically asking them to say, here's what we've been able to do on our own with the current structures in place at the regional level, and here's where change is needed, and recognizing the places where they can make change on their own, and the places or policies that need to be changed at the state level in order to support them. So that will give us a lot of feedback at the state level for the innovation project to say, if we're going to continue to support and move forward to this vision, what needs to change in terms of policies, practices, and finances at the state level, and which ones can be changed at the regional level. And so that's what we really hope to learn. And by doing this, by participating, the peer learners will be able to, as I said, share what they've already done, learn from others who might be approaching it somewhat differently, and also have the benefit we will be bringing in some of our national leaders topically as identified. If the peer learners say that there's a topic that they really want to explore and nobody here in Vermont is ready to do that, we will bring in some national speakers through webinars to do that. So we have already sent out notice to the folks here in Vermont, many of whom have responded really positively to participating in the peer learning laboratory, which we hope to have our in-person meeting in the near future. And we will be looking forward to starting that once we have a contractor on the ground to really help us with the laboratory design. Was there something else you'd like me to share about the peer learning laboratory?
No, that was great. Thank you so much, Heidi.
Sure.
And I also want to thank you all for attending today's webinar, Defining Population Health Strategies, and a special thanks to Heidi Klein for presenting on this important topic. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Vermont Healthcare Innovation Project, thank you for joining us today, and have a great rest of your day.